Thank you very much for this kind introduction. Good morning, everyone. My name is Demolder. First of all, I'd like to thank the organizers for providing me the opportunity to present our research here today. Let's see if we can get our slides here on the screen. Yeah. So good morning, everyone. My name is Demolder. I'm a research physician. I work at the OLV Aalst Hospital in Belgium, and these are my disclosures. I'm affiliated with Powerful Medical as we do AI research. So let me briefly go back. Today I will talk to you about a smartphone-based AI model to detect left ventricular systolic dysfunction on a 12-lead ECG. So we all know that the diagnosis of LV systolic dysfunction is definitely a hot topic in our field. Unfortunately, this diagnosis traditionally relies on echocardiography. And we know echocardiography is an imaging modality that is resource intensive. It's not readily available everywhere. And we also know that it is expert dependent. So we need experienced sonographers to perform echocardiography. We also know that the diagnosis of LV systolic dysfunction is only performed after developing symptomatic disease in most patients. And now this is unfortunate because the symptomatic disease stage does not really represent the earliest stage in this disease. We know that an early stage diagnosis is actually desirable in these patients, but unfortunately they often present to the hospital with an acute episode of, for example, heart failure exacerbation. We also know that there is currently a lack of effective screening strategies present, and that is because there is no tool for a rapid assessment of LV function that is available in primary care or that is readily available to anyone. Now, we also know that effective treatment options exist for these patients. There is a whole arsenal on medication for these patients. I don't have to explain you all the different pillars there are for treating heart failure with reduced ejection fraction. We also know that there is device therapy available. And now, what's interesting is that there is also evidence supporting earlier screening of these patients. There was, for example, the SOLVE trial showing benefits of ACE inhibitors in asymptomatic reduced LVEF patients. There was also the STOP-HF randomized trial published in JAMA, where there was a benefit of using NT-proBNP as a screening tool. And they showed that there was benefit on hard endpoints in that study. So with this in mind, we set out to develop two AI models that were able to detect reduced left ventricular ejection fraction on a 12-lead ECG. Specifically, we designed one model to detect LVEF below or equal to 40%, whereas we developed another model to detect LVEF below 50%. This is in concert with the guidelines we currently have. Now, we also wanted these models to be smartphone-based. So we want to pair them with our previously developed ECG digitization technology. And this way, we can make it much more accessible to any physician. And lastly, we performed an analysis of our AI model performance, but we also checked at NT-proBNP. And then we also went a bit further and looked for a longitudinal analysis of these cases. So, our methods. We collected over 1 million ECGs from the OLV Aalst Hospital data vault. We also collected almost 300,000 TTEs available in the data vault. And then we paired the ECGs to the TTEs within a time window of 24 hours. This is because we want to have the ECG representative of the TTE. Next, priority was given to the Simpson biplane measured LVEF over the visually estimated LVEF. And now, if we look at our flowchart here, first we did some pre-processing and also data quality checks to make sure that the data was of sufficient quality, eliminating TTEs and ECGs that had more than 24 hours between them. And then next, the pairs, the ECG-TTE pairs, were randomly assigned to either the model development set or the validation set. For validation, only one ECG one ECG TTE pair per patient was allowed. And I want to highlight here that in our validation set, we had more than 25,000 patients that we used as a validation. Looking at our results, I can show you here the AUC curves. We can see that both of these AI models actually have excellent performance. Both of these AI models have an AUC over 0.95, with a sensitivity around 90% and a specificity around 88%. This is very impressive because these are some of the highest AUCs that have been presented here at the conference. And now next, we also looked into subgroup analysis. We saw that if we look at the demographics of these patients, there was consistent performance of the AI model across age, sex, and BMI. Now, if we look a bit further and we look into the electrocardiographic subgroups, we saw actually that there are a couple of subgroups where we have reduced specificity. These subgroups include patients with atrial fibrillation, patients with a pace rhythm, but also patients with left bundle branch block. We noticed that there is a drop in sensitivity and specificity in these patients. Next, we also performed an analysis to see how our AI model compares to NT-proBNP. So here I can show you this box plot graph where we look at if the AI is predicting a normal ejection fraction and the echo shows a normal ejection fraction. You can see the result at the top. If the AI is predicting a normal ejection fraction but the echo shows reduced ejection fraction, then you see an increase in proBNP. But the proBNP further increases when the AI showed a reduced left ventricular ejection fraction, but the echo remained with a normal ejection fraction. And lastly, the most highly noted proBNP levels were seen in patients having an AI-predicted reduced LVEF combined with an echo that also showed reduced LVEF. And now, for my final analysis, we also did a longitudinal analysis of false positive cases. What are the false positive cases? These are patients who had a normal ejection fraction on TTE at time point 0, but the AI model predicted that they had a reduced left ventricular ejection fraction. And now we set this out in a Kaplan-Meier curve to see what is the incidence of developing reduced ejection fraction over time in these patients. We see the false positives in blue, and if we follow them up over a time period of 10 years, we notice that these patients have a significantly higher tendency of developing reduced left ventricular ejection fraction. Even so, after 10 years, we see that almost 70% of these patients have developed reduced ejection fraction over time. And this is something that's very interesting because it highlights also a new background to the term of a false positive. What is a false positive? If the AI can see that it might be detecting earlier stages of reduced left ventricular ejection fraction. Now, dear colleagues, it's been already raised a couple of times today, but I want to talk to you about clinical implementation. You are all wondering, this AI model, how can we use it? Is it stuck in some computer? How can we get this AI model to primary care or to every physician here in the room? And for this, I actually have the solution in my pocket here. My smartphone already has access to all of these AI models. And now I know every one of you in this room has a smartphone. That means that I can provide you, every one of you, access to this AI model through your smartphone. It also means that I can provide physicians in primary care who are capable of taking an ECG. I can also provide them with access to this AI model. And this is very interesting because this can signify widespread adoption in the future. Let's do a demonstration. So we have an ECG here of a patient, a male, 69 years old, who presented to his GP with occasional shortness of breath during exercise. And now the GP started scratching his head and wondering, shortness of breath during exercise, this could be the heart, this could be the lungs. The GP took an ECG, and then he said, okay, I'm going to refer you to a cardiologist. but the patient had to wait 6 weeks to get his echocardiography. And then at 6 weeks, the echocardiography was performed, showing a reduced left ventricular ejection fraction of 38%. But now, what we can do, we have our smartphone with us, and we can take a picture of this ECG. And what we can effectively do is digitize this ECG quite nicely, as you can see here on the screen. And then based on this digitized ECG, we can get an AI algorithm prediction for this patient. So our AI algorithm here predicted that this patient has reduced ejection fraction with high confidence. And now this brings me to my final slide, my take-home messages. We've shown that we have developed 2 models that have excellent performance to detect reduced left ventricular ejection fraction on a 12-lead ECG. We've also shown that we can integrate these models into a smartphone, making widespread adoption possible. And this presents a potential tool for rapid assessment of left ventricular function. And lastly, for future prospects, we have ongoing external validation studies. And with this, I also want to do a warm call to every one of you. If you would like access to this model and you want to study it and you want to join our external validation efforts, please come see me after the presentation, and then we can see and collaborate together. My name was Dr. Anthony Demolder, and I thank you for your attention.
Thank you very much, Anthony, for this interesting presentation. Are there any questions from the audience? Yes, please.
Hi, excellent presentation. My name is Rishi Trivedi. I'm a cardiology fellow and AI researcher at Cedars-Sinai in the U.S. I'm curious, the echoes that you used for the training, do you know what the volume status was for these patients? So are these echoes outpatient, inpatient, decompensated heart failure or not? Because that really does affect what you're actually detecting on your ECG.
Yeah, that's an excellent question. So indeed, the echoes were used, so we used all echoes within the hospital. So this meant we had patients from both the outpatient setting, but also from the inpatient setting where they had acute exacerbations of heart failure. Prevalence of heart failure in this population was ranging around 10%, which means that indeed we can look further, because if you want to use this model in primary care, where you have much different prevalence and a different population, we have to check like how is the model performing in the outpatient setting, in the inpatient setting, but also in primary care. So that's an excellent point you raised, and we have to further validate this. I agree.
Microphone 1, please.
Hi, my name is Manu Agarwal. I'm one of the cardio-oncologists at Cleveland Clinic. Excellent presentation, thank you. My question is, I do see like a recurrent theme in all the AI presentations being saying there is a lot of waiting time for the physicians or for the investigation, so efficiency can be increased. There is a majority of the world for getting an echocardiogram on the same day is not a problem. Like majority of the Asia, you can just walk on the street, and if you want to get an echo, someone will do echo. How do you see such models or such applications addressing problems more than just increasing the efficiency?
Yeah, that's an excellent question. So we know that this AI model is now capable of detecting reduced LVF. In the current setting, we would aim to use it as a sort of screening tool to identify those patients who would be benefit for a referral for an advanced echocardiography. But we can also use it as a screening tool to maybe reduce patients who don't need a routine echocardiography, for example. If I hear you're a cardio-oncologist, as you know, a lot of patients get an echo, for example, for screening for cardiotoxicity when they have cancer medication. And if you do 100 echoes for screening for cardiotoxicity, you know that most of these echoes will come back as a normal ejection fraction. And maybe this tool could be used as a sort of a screening for these patients, picking up on those patients who would need an echocardiography, but also reducing the needs of some other patients who have normal ejection fraction and would maybe not require an echocardiography.
If this AI tool gives me liability and malpractice insurance, I would use it. Thank you.
Yes, please.
Thank you for the presentation. My name is Pablo Perel from the London School of Hygiene and Tropical Medicine. You mentioned the practical aspect of that is really interesting, taking a picture. But what I'm curious is, in the model development, you didn't use pictures, you used raw data. Can you explain how the accuracy of the model developed apply when you take picture? And the other thing, maybe it's more like a comment. You mentioned the very high area under the curve, but it's true, as you acknowledge at the end, that it was only internal validation because it was a random sample. So it's likely that might be overfitting, and I think it's important to validate in different settings and different populations.
Absolutely. I fully agree. This is a very important comment. First of all, the model was indeed trained on the raw ECG signal, but in our validation set, we also simulated the digitization because we know the digitization process inside and out, and we can replicate this process and apply it to the digital signal to see if we can achieve the same performance in these digitized ECGs. Second, we have ongoing external validation studies who are using the smartphone application to digitize the ECGs. And there in preliminary results, we show that the performance is actually consistent. But unfortunately, at the time when I had to submit this presentation, I was not able to add the analysis results yet.
Sorry, and this smartphone application, is that available already, or is only you're using only in a research setting?
So currently we are using it in a research setting, but we plan to make it available publicly very soon. If you would like access to it, just come see me and I can provide you access, and we can definitely do a validation study together if you like.
Thanks again for your presentation.
My pleasure.